had this discussion about going forward, and I said, I have to check with the residents. And I met with the residents behind closed doors, and there was zero dissent, an absolute 100% agreement and alignment to appoint Dr. Patel as a program director. I honestly didn't believe it, went back again to the residents 2 weeks later and received the same results. 100% agreement on appointing Dr. Patel as a residency director. And I'm thankful and grateful for that. I appreciate your dedication, holding me accountable, making the faculty, residents, and your chair a better educator. We're looking forward to learning from your talk today about difficult discussions and surgical emergency. Dr. Patel, it's great to have you with us.
All right. Good morning, everyone. So thank you for the really kind introduction. I will say that when I was invited to Dr. Oliphant's house, I thought, man, am I getting fired? But usually I think they don't invite you to their house to fire you. That happens at the workplace. So I thought that was okay. So something to keep in mind, in the future, if you're ever called to someone's house for a meeting that you have no idea what it's about. It's my honor and privilege to be able to give grand rounds again today. I'm hoping to take about the next 40 minutes or so to talk a little bit about difficult discussions and surgical emergencies. I think that this is a really important topic. We've had flavors of this, I think, in the last academic year. This, I think, comes up very often. It's a big topic, and I won't be able to really do it justice today, but I'm hoping that it will at least pique some of your interest and give you some cause for self-reflection. I will apologize in advance. I'm using a little bit of a different program this time, so I have to be very careful to keep my phone oriented this way. So if you get a little bit of vertigo from the screen flipping, please bear with me. I have no disclosures. As usual, I am obligated to say I'm still looking for corporate sponsorship. My answer has not changed since last year. So if anyone has any industry partners who would like to pay for me to go somewhere nice, please let me know. As part of Creighton's Grand Round Lecture Series, they ask us to reflect on the Ignatian values as part of whatever content that we're delivering. And I think the one that's most pertinent for today's topic today is care personalis, or care for the whole person. And I hope you'll see that by the end of our time here today. So I think it's always something that I reflect on when preparing for these talks is, what is the audience? Anytime you're getting ready to give a lecture or speak your talk, who are you trying to deliver a message to and what do they care about? And I think despite this being a surgical grand rounds, it's still a very diverse audience. People, are largely focused on surgery here, but we have medical students who may or may not be surgeons, although surgery is definitely the best specialty. I am begrudgingly willing to acknowledge that there are other valid paths in medicine. That said, we have surgical residents, we have surgeons, we have many candidates on Zoom who have chosen to pursue careers in surgery. And so I always want to choose something that will at least appeal to maybe 60 to 80% of the audience. And so I hope that even if you're not a surgeon, that some of the tools and some of the points that we'll discuss here today will be relevant in your future careers or give you some thought in the future. One of the things that I really like to do every year, because this seems to be around the time that I give grand rounds, is to comb through the sessions at ACS. So I was privileged to be able to attend this year, as I know some of you were as well. And if you weren't able to attend, I really encourage you to take advantage of the virtual platform. They have hundreds of fantastic recorded lectures. But these are two that caught my eye, and I have shamelessly borrowed from them in order to inform a lot of this talk. So if you have an opportunity later, I do encourage you to seek out these sessions and the many others that are available. I think I wouldn't be doing anyone any service or being a good role model as a surgical educator if I didn't have learning objectives to start the lecture. So these are the three things that I hope by the end of the lecture you will come away with. One, if you could list some risk factors that increase surgical morbidity and mortality in adults, that would be great. I hope you'll be able to define shared decision-making. And finally, demonstrate how to use the best case, worst case tool to guide goals of cares discussions. So we'll start with a case vignette. I think this is a pretty familiar scenario, but you can imagine, any number of variants on this particular scenario. You're on call, taking emergency general surgery call. They call you and they say they have a patient with free air. She's 75 years old. CT scan shows pneumoperitoneum. She's febrile, hypotensive. She's confused. They say she's peritonic exam. You look at the chart. She's got a leukocytosis, acute kidney injury. Her lactate is 3. The CT does in fact show pneumoperitoneum. The radiologist can't exclude a mass in the left colon. So, this is, I think, familiar to most of us and something that, I feel like I see every other week. So this is the part where I say, I think lectures, unfortunately, they're necessary, but they're not the greatest form of educational delivery. So I am hoping to get a little bit of audience engagement. So just, show of hands, does this patient need an operation? Okay, so I would say like maybe 60%, and then like 10% who think yes, but don't want to raise their hands. But I think the real question, and what I hope to get at a little bit further in this talk, is should this patient have an operation? So how many of you have a different answer to that than you had to the first question? Okay, so I think probably about half, and I think that is really important and really thoughtful. All right, so here's a little bit more information. You've gone down to see the patient. You learn that she's coming from a facility where she's resided for the last several years. She has a history of diabetes and dementia. So keeping in mind that you got a little bit more information, and maybe the question is really, should this patient have an operation? What kinds of things do you want to know? What more would you like to know to help make your decisions? Dr. Wade.
Sort of quality of life currently.
Okay. And what does that mean?
What are kind of ADLs does she perform on her own? What kind of interaction with staff, family does she have on a daily basis?
All right.
Kind of going off that, what's her advanced directives? Like, what has she stated in the past? How has she communicated with family? What is her goals of care? All those sorts of things.
Fantastic.
Who makes medical decisions for her?
Great. All right. Well, I think we can just wrap up here. You guys have basically answered, 5 or 6 of the slides already. All right. So we get some more information. She's minimally ambulatory at baseline. She's had multiple falls over the last year. Her caregivers at the facility have noted a worsening cognitive decline. And unfortunately, she does have family who are engaged, but they're several hours away. So most of your conversations with them are going to be over the phone. So I think that this is a challenging situation to deal with. We don't have a lot of information. The people who could give us that information are a little bit more remote, and it's harder to have those conversations, I think, over the phone. So keep that case in mind. We'll come back to it again shortly. So I wanted to start by addressing that first learning point. So a lot of the tools and things that we'll discuss, over the next 40 minutes or so, I think are applicable to any patient population, anyone who's sick, anyone who needs an urgent or emergent surgery. But I know that we increasingly take care of an older patient population. They have more medical problems, and unfortunately, they need emergency surgery. And I think that this conclusion is non-controversial, that these patients have increased morbidity and mortality. And there's a lot of different reasons for that. And, it's a huge field of research. If you, do this PubMed search, you'll probably get thousands, hundreds of thousands of hits. But they have less physiologic reserve and older, so-called biologic age. They're multimorbid, they're frail, they have reduced cognitive and functional reserve. And all of this leads to increased morbidity and mortality, which I think is not a controversial conclusion. A lot of the ways that we kind of assess risk really focuses on the patient's age, maybe their BMI, numbers, what are their comorbid conditions, what kinds of, acute physiologic derangements do they have. But I think that when we think about assessing risk in our older patients, some of these phenotypes that contribute to their decreased physiologic reserve or that older biologic age are really more useful to think about. And the purpose of this table is not, to memorize these tools for assessment, but really just to note that, across these domains, when patients have these risk factors present, it substantially increases their risk for complications, delirium, hospital length of stay, and morbidity. So these patients are utilizing a lot more resources. They're sicker. They're going to have worse outcomes than their younger cohorts. As you would expect, frailty is a significant contributor to morbidity and mortality in these older patients. And this is one of those things where I think, as you move along in your medical training, you'll kind of often know this when you see it. But there are scoring systems which can be really useful to screen patients for frailty, when it's not always obvious. Sarcopenia, that kind of wasting muscle mass. Again, oftentimes you'll know that when you see, but sometimes it's a little bit more occult. The patient may have great functional status, but they could, be sarcopenic, and that sets them up for a number of different complications, malnutrition, cognitive dysfunction. And then I think it's really important to note their functional status, as you guys mentioned, when you wanted to know more about what this patient is doing. And all of these things, again, more complications, they stay in the hospital longer, increased risk of death, increased risk of complications. So if you think back to that case, someone just throw out a number. What percent, over 30 days, do you think this patient's mortality is?
More than 50%.
More than 50. All right. Anyone else have a guess?
Lower than 50%.
All right. So, Price is Right rules. So thanks for playing along. All right. So as you guys know, there are a number of different risk calculators that are available to help us quantify the risk of mortality and morbidity. I think the ACS NSQIP calculator is probably the most, widely known and the most widely used. And it is really an incredible tool. So NSQIP is the National Surgical Quality Improvement Program. And basically, this is a nationwide registry for many participating hospitals. At the time that they developed this risk calculator, it was about 400 participating hospitals, and I'm sure it's more since then. And they have a really high quality registry of patients who have undergone index operations and general surgery and in other fields. And from this, they did a lot of linear regression and math to come up with a universal surgical risk estimation tool. So you go on the website, you put in all of these patient factors, and you get this really nice chart, which unfortunately for our patient shows a lot of red and just a little bit of green. So red is above average risk. So, ACS, plugging in the numbers from our patient, and I, I gave her like an average BMI and some other things that they asked for. Didn't make her too sarcopenic, but about a 20% mortality. So, one of you guys was right and you had a 50-50 shot, so that's pretty good. Now, there are limitations to tools like this. A lot of them are based on linear regression. And so people have spent a lot of time trying to use things like AI and machine learning to really suss out, more nuanced prediction tools. Because again, NSQIP is kind of designed to be this universal catch-all. You can put in a CPT code and all these patient factors, and it is, as it states, it aims to be a universal risk calculator with the drawbacks that entails. So, if you have a specific complication or condition you're looking up, you'll find, again, hundreds of studies that have looked at that particular thing. But unfortunately, they tend to be a little bit unwieldy to use in practice. Now, specific for emergency laparotomies, there is another calculator that I did want to just highlight. This is the Potter calculator, which is an acronym for predictive optimal trees in emergency general surgery. So this is using not machine learning and not using linear regression in order to predict risk. We're fortunate to have the first author here to kind of explain to us all this complicated math. So Vahe, congratulations, this is great work. I think one of the advantages of this is it's specific to emergency laparotomies, which again is the focus kind of risk and discussion making in this particular talk. And it performs very, very well. If you look at this paper, the receiver operator characteristic curves look really impressive. And really the most useful aspect of this is they have a phone app. So you can use it on the fly and download it. And this calculator, I'm sure you can use on your phone, but it is a little bit cumbersome to use on the fly. But if you do have a moment, you can run up to a computer and kind of plug in your patient's numbers. I did want to mention, with ACS NSQIP, Dr. Clifford Coe, who is one of the ACS heads for the quality improvement, will be giving us grand rounds in March. So this is, again, I think a really important and useful tool for us. So our patient, if we plug her into the Potter risk calculator, mortality is similar to NSQIP, a little bit over 20%. The risk of morbidity is high, as you would expect. You saw those red bars on the previous page. So an 85 risk of having any complication. And then I pulled out one specific complication, which is prolonged mechanical ventilation. So when we think about, what happens after surgery, I think understanding the specific risk profile is important, because an 85% risk of any complication, it sounds bad, but what does it mean, right? Is this, they're guaranteed to have a superficial surgical site infection versus they're not going to come off the ventilator, they're going to need renal replacement therapy. So there is some nuance to that. And that is, I think, important to be able to pull out what is the specific risk of certain complications and what are the ones that are important, to the patient? What are the patient-centered complications here? And unfortunately, about a 40% risk of being on the ventilator for more than 48 hours. So down to our second learning objective, defining shared decision-making. So shared decision-making has been around for a long time. I think in medical school, you're probably taught kind of the historical curriculum of this kind of, physician down type of decision-making where you decided what's best for the patient and they just sign up for treatment and the ride. But shared decision-making really shifts that focus more towards a patient-centered outcome. So the Agency for Healthcare Quality and Research defines shared decision-making as a collaborative process in which patients and clinicians work together to make healthcare decisions informed by evidence, the care team's knowledge and experience, and the patient's values, goals, preferences, and circumstances. And I think that, sometimes these definitions can feel a little bit abstract, but I think, as we've moved from this kind of top-down approach to medical decision-making, sometimes there's a shift to kind of moving everything to the patient, where we present them with all of these options, all of these numbers, and we say, make a choice. And we don't offer our own opinion. And really, I think we're doing the patient a disservice if we don't give them the benefit of our knowledge and experience. And that's really what you have to do as a surgeon. I strongly believe that what differentiates surgery, and in particular general surgery, from other procedural fields is that we're not just technicians. Not to disparage our radiology colleagues, but when you ask them to do a procedure, they just do the procedure most of the time, unless it's something they technically can't do. But I think as a surgeon, you're really deciding, is this the right procedure for the patient, or maybe we shouldn't do anything at all, or maybe there's a third option. You are that patient's doctor. You're there to help take them through this process. And sometimes the answer is not surgery, and you have the expertise to help them decide that. So you are taking what the patient values and helping filter it through the lens of your understanding of these complicated numbers and complications, and helping them arrive at a decision that makes the most sense for them in their particular circumstance. So it isn't about you, but it is a little bit about you when we're going through shared decision making. So one of the ways to help have these conversations and make these decisions is the best case, worst case tool. There are lots of different tools out there that can do this, but I think this is one of the ones that is probably now a little bit more well known. It's been around for about 10 years or so, which now feels like a long time. I actually heard about this in 2022, and I didn't really think that much of it, although it did stick in my mind, as something that could be useful. I was at my first ACS, which I think was in San Diego, and I, for some reason, decided that I would sign up for this kind of 1 hour little breakout session that was called Updates and Informed Consent, because I really was just thinking, like, what updates could there be in informed consent? So, my curiosity was satisfied, and this was one of the things they presented. And I actually, if my memory is not faulty, I think Gretchen Schwartz was the facilitator for that session at the time. And again, I didn't really appreciate the great work that she was doing or the benefit that I had at the moment. This work came out of the University of Wisconsin, where we also got the great Scott Reitz from. And basically what this is a communication tool that assists physicians in discussing options with patients and implementing the treatment plans that are in alignment with the patient values and preferences. So this is really a way to engage in shared decision-making in a structured approach, rather than kind of having to reinvent the wheel for yourself every time. So in their original paper, they had this nice schematic that I think is very illustrative of kind of the journey that we go through when we're making these difficult decisions in collaboration with the patient. So the first thing is kind of the choice talk is how they phrase it. And this is where, we're kind of delivering bad news, right? So the patient, may or may not know they have a problem, but eventually either you're a physician who got the CAT scan, or when you go see the patient, you're going to tell them that, you have a problem that oftentimes surgery can correct, and it's a serious problem. Again, there's many different tools to deliver bad news, and we'll touch on one in a few slides here, but I think it is important to be very clear with the patient that they are here to make a decision, and you're going to help them with that. The next part is the option talk, and this is where the best case, worst case tool kind of comes into play. And so what we're trying to do here is take those things that are abstract, like what does it mean to have a 40%
What? It does?
greater than 2 hours.
Oh.
And turn this into something that's meaningful for the patient. And then ultimately we have to
Do
make
you
a
want to
decision.
listen to this?
You as a clinician should provide a recommendation. And then there are things that happen afterwards.
Okay.
So the first piece, again, that choice talk. So this is kind of, some form of delivering bad news, which I think is now probably integrated into every medical school curriculum. I remember being a little bit amused learning the spikes in mnemonic when I was a medical student, because leave it to medicine to develop an algorithm for delivering bad news. That being said, despite my skepticism, it actually works really well. You don't have to follow it exactly, but I do think it gives you a really nice framework that's very reliable and very reproducible when you're having these conversations. Because oftentimes, in the heat of the moment, there's a lot of stressors. You have other consults pending. You're trying to have this very serious conversation. You can forget things. And sometimes having a way to, structure those conversations and practice them in a deliberate way, I think can be really useful. And again, I think one thing that I would just add as my personal aside is that you have to be very clear with the patient about what the stakes are, avoiding things like euphemisms like pass away. You have to be clear that if there's a risk of death, you need to be clear when you tell the patient that you could die, or you may die, or you will die. I think that sometimes they walk out of those conversations with a different sense of what the possible outcomes are. And again, I think that does a disservice to the patient. So this is the pocket guide to the best case, worst case tool. On that QR code on the previous slides, that's a link to the toolkit for this. And so if any of you are ever inspired to go back and want to teach this to someone, they have developed a really nice, kind of 1 hour little module you can do that has instructional videos and different cases that you can go through and kind of walks you through how to use this tool. So again, the first thing is, establishing that there's a choice to be made. And then what this looks like when you are doing it in the way that they originally intended is you would actually draw out kind of the best case and the worst case. So each of these vertical lines represents a treatment pathway. And kind of in the simplest forms, the treatment's usually going to be like surgery or no surgery. But you can have more than one line, because sometimes there are things that are in between, less invasive options. For example, resecting a colon cancer that's obstructing versus placing a stent versus doing no intervention, or a goal-oriented intervention. Then at the top, we talk about what is the best case if we pursue that particular line of therapy. And at the bottom, what is the worst case if we pursue that particular line of therapy. And then in the middle, this is where the clinician judgment, I think, really comes into play, is what do you think is likely to happen if we pursue this particular treatment pathway? And what this helps you do is give the patient a story. And so this is a little bit of narrative medicine, where we're taking these risk calculators, where we could just hand the patient that NSQIP sheet and say, here are your risk of these complications. But they really don't understand. I think some of you have maybe heard me say that I think informed consent is really impossible, because I'm a surgeon, but if I was to have a knee surgery, I could not truly fathom all of the possible complications of that surgery, because there are just so many things that can happen that are within the realm of possibility, and most of them are rare. But really, what does this look like at the end? It's something that without specialized training and experience, you really cannot comprehend. And so that's where I think as a clinician, you have to help shape that story for the patient in terms that make sense to them and help you figure out which of these options is going to align most with their goals and values and preferences. So coming back to our patient, here's kind of the summary of what we know about her. So I think, let's say that option one is laparotomy, colectomy, Hartman, something like that. And option two would be, a focus on comfort. So maybe the best case if we intervene here is that you remove that perforated segment of colon, and let's say it happens to be a cancer. You do a great operation, negative margins, 15 nodes. She stays in the ICU for a day. She goes home after 5 days back to her living facility with some outpatient therapy and does great. Maybe likely, I don't think so, based on what I know about this patient and what's been informed by those risk calculators. What could happen? You do an operation, she comes to the ICU, she's intubated, she's on multiple vasopressors, her renal failure doesn't get better, she requires renal replacement therapy, and then at the end of 10 days, she still dies. So maybe that's the worst case. Let's say we don't intervene with surgery, we focus on managing her symptoms. Her family has time to arrive. They're able to spend some time with her, and she dies peacefully in minimal pain. Maybe that's the best case for a non-surgical intervention. And I will add, just again as a little aside, oftentimes when we talk about not doing surgery, people think that this is not intervening, but oftentimes to palliate, it requires aggressive treatment. Treating pain and symptoms at the end of life or in kind of, terminal or severe surgical conditions actually requires a lot of effort. This is maybe even harder than actually doing surgery. And maybe the worst case there is that we can't control her symptoms, her family never gets here, and she dies, and it happens very quickly. So I think that with all that in mind, we have to still make a recommendation. And the question is, my question to you at this point is, do you have enough information here to make a recommendation? So Dr. Brown, Dr. Scarborough, they're shaking their head no. And I would agree with you, because while we know about the patient's background and their functional status, we don't actually know anything about the patient's values, preferences, or goals at this point. And unfortunately, this is a challenging situation that we often encounter because we don't have the patient to tell us those things at this point. And so we're reliant on her surrogate decision makers, her family, to help us inform that decision. But when we're doing that, again, we have to really, I think, relate back to the story that we're painting about what are the realistic options and potential outcomes of this situation. So, we've more or less covered, I think, the first 3 learning objectives. We talked about risk factors for morbidity and mortality in older adults. We defined shared decision making. I gave you a glimpse of how to use the best case, worst case tool. I still want to take about the last 10 minutes or so to go over a few more things. So we've made one decision, which is what we're going to do. Now, let's say that it was congruent with the patient's values to proceed with the surgery in this case. Okay, the easy part is done. We can do the surgery. That's technical. That's actually the easiest thing that we'll do probably in this entire case. Oftentimes, I think that regardless of which path we choose, it's important to have a way to document this both for ourselves, both for the patient's family, and then for other members of the care team. And even if you don't think that this is important, although I think that this is really important, I will say that the American College of Surgeons thinks that this is important enough that in the verification standards for geriatric surgery, it's an entire section, included in these optimal resources for geriatric surgery. As many of you know, the ACS has a lot of quality programs, one of which verifies us as a trauma center, and hopefully soon will verify us as an emergency general surgery center. But they have produced this really nice document on resources for geriatric surgery. It's very well written. It's very concise. I would encourage you to skim it. But one of the things that I think is really helpful that came out of it is, what are the things that you need to actually write down that may be helpful after you have these discussions? Because, I feel like, these discussions can be very charged. It can be emotionally draining. And when I walk out of them, I could write a book chapter. I could write a book report on this conversation. But what is the key things that we have to write? So one, I think this is really nice, is actually, if you can, get a verbatim quote from the patient about what their goals are. What do they want to see happen? And then 2, that you discuss the impact of the surgical and the non-surgical options. And I think this is key. Look at the things that they talk about, like the symptoms, the burden of care, the living situation. And survival is the last thing. So it's not always just about mortality. It's really about, we talk about quality of life. What is important to the patient? Will they be care dependent? We see this so often in trauma, where the patient, will live, but they will be totally dependent on cares for the foreseeable future. And so maybe that's not something that's congruent with their values. And then what did you recommend? And then how was that informed by your discussion with the patient or their surrogate decision makers? So, once you've done that documentation, I think, and you've done an operation, it's unfortunately not over. And so I think there are some things that are really helpful, if you can, to try and establish when you're making this decision about, pursuing an intervention, because this gets much harder afterwards. 1 is code status, and 2 is kind of what interventions are going to be acceptable afterwards, because this is a sick patient. Almost certainly they're going to come up to the ICU. They may be on the ventilator. They may be needing vasopressors, and not every situation is like this. And oftentimes you can predict in advance, if a patient is going to go to the ICU. And sometimes it's a surprise, but when you know, I think it is really important to try and address those elements of care. And again, that was included in the ACS standards for geriatric surgery. When you anticipate a post-op ICU admission, you should address the patient's willingness to accept all of these types of interventions that may be very invasive, life-sustaining treatments. So code status, one thing that I think comes up from time to time still is that the patient has to be a full code, before they can go to the OR. And this doesn't always come up, so much with the surgeons, but I think amongst, allied healthcare professionals and allied staff, like, oh, well, they're a DNR, we still have to do surgery. And being a DNR does not preclude surgery. In fact, the ACS, statement on this is that it would be unethical to unilaterally change a patient's code status or to deny them surgery just on the basis of them being a DNR. What is important is something called required reconsideration. So especially when a patient comes and an intervention or a surgery is in line with their goals and values, but they have a pre-existing DNR order, we need to think about what that means. And a lot of this gets not as clear cut as we would like, because when you're in the computer and putting in someone's code status, your options are DNI, GNR, full code. There's not a lot of nuance to it. And so this is where communication is really important. Understanding, are we temporarily suspending this DNR order? And does that mean that we're going to do the full spectrum of resuscitative measures? Will we do chest compressions? Will we defibrillate? And that is, again, a discussion to have with the patient. And then once you've had that discussion, it's a discussion that's really important to have with the rest of the care team. And you as the surgeon are the one who's had this discussion with the patient. You know them, you're the one offering the intervention. The anesthesiologist will meet this patient for emergency surgery, 10 minutes before their surgery happens. And they're not going to have the opportunity there. So you have to help inform the rest of the team that this was the discussion you had and this is what we're going to do in this situation, especially if this patient is, really critically ill, at risk of death, even in the OR. Are we going to do chest compressions? Will we defibrillate? Things like that. And so, incorporating that as part of your, pre-brief or timeout in the OR, I think is important. This QR code goes to the AAC Palliative Care Committee page, which, I should say is probably a non-financial, corporate disclosure that I am on that committee. And we're working on a kind of one pager for what to do if a patient comes with a pre-existing DNR order and the plan is for surgery. It's not live yet, but will probably be up in the next couple of weeks. So I think it'll be a nice resource. But one of the things that when we were developing this that I thought was really nice is a way to help avoid kind of a menu or a checklist of interventions. And this is a trap that I myself, have fallen into, all the time. Would you be okay with intubation? Would you be okay with dialysis or, X, Y, or Z? And so while it doesn't completely remove this element of kind of a menu or a checklist, kind of framing things in terms of intensity or levels of interventions that might be acceptable may be better. As a prerequisite for most surgeries, you have to accept intubation, but maybe you don't want to accept, re-intubation. But somewhere in between, it's a spectrum, right? Antibiotics, sure. Vasopressors, cardioversion, maybe that's okay. Maybe you draw the line at, chest compressions, defibrillation, ECPR, all of those things potentially are on the table. And so maybe framing it in terms of kind of where in that spectrum things would be acceptable, it might be a more useful way to have that conversation with the patient. Postoperative management, I think, again, can get nuanced. And if you have the opportunity at all to have even a little bit of this conversation before the patient goes to the OR, I think it's incredibly helpful. So, one, as you guys mentioned, like who's making decisions for the patient? Because, let's say not in this situation, but if the patient comes to you and they're alert and oriented and you've had this great conversation about what they want and what their values are, I think it's really great to find out, who, let's say you're going to come up to the ICU afterwards and you're on a breathing machine and we can't ask you these questions. Who do you want to speak for you? So identifying their surrogate decision maker, I think, is really important to do ahead of time, if at all possible. And even better, if you can get that person involved in that conversation, just for them to listen so that they can hear for themselves what the patient is saying. I think that also reduces a lot of the angst and conflict for the family and for the physicians afterwards. When we're talking about maybe things are not going as we had hoped. And we're talking about maybe moving in a different direction away from curative intent, maybe towards comfort-oriented care. If the patient has any kind of advanced care planning, advanced directives, obtaining those is really useful. Even knowing that they exist, I think is helpful because, then at least you can say, okay, we know they have it. We just have to go have someone go get it from the house or the safe or wherever it exists. A lot of states have things called POST forms, physician's order for life sustaining treatments. That was very big in California when I did my fellowship. And what was nice about those is they were actually very explicit about things that patients would and would accept. I would be fine with artificial nutrition for this period of time, or I would never want any form of artificial nutrition. And so that helps remove a lot of the decision-making and uncertainty from both the surgeon and the family afterward if the patient can't participate in their care. And then when there's this question of equipoise, where they're not sure, they are not ready to make that decision, but by delaying the intervention, you entirely lose the opportunity for any kind of good outcome, so to speak. It may be reasonable to offer a time-limited trial. We can do this, and if you're on the ventilator for more than X time, then we will reconsider and talk about moving towards a different direction in terms of goals of care, away from curative intent, maybe towards focusing more on comfort. So, like I mentioned at the beginning, this is a really large topic. We could talk for hours and hours about this, but I will spare you from hearing me speak for more than about 40 minutes or so. But I just wanted to touch on a few other things that I think, again, are worth kind of reflecting on and kind of highlight the complexity of this issue. So one, you can be in situations where the patient lacks capacity, there's no surrogate decision maker available. Those situations can get complicated. You can have conflict among surrogate decision makers. Maybe you have multiple surrogate decision makers who seem to have kind of an equal claim to that title, and they're saying different things. This is where social work case management ethics can be helpful for you, but these situations almost always are very difficult. And, while hope is not a plan, sometimes you just hope that by having a conversation with them, you can get everyone on the same page, but sometimes that doesn't happen and it can get very complicated, both for you and them. Sometimes, the patient and the surgeon have this disconcordance, this dissonance, and that can be very emotionally distressing. You can moral injury. You may feel like you're not doing the right thing for the patient. And then I think the biggest thing, which is true for so much of what we do, but particularly hits home for me, doing trauma and acute care surgery and critical care, is that sometimes the risk is just not estimable. You can't realistically figure out where on that, best case worst diagram the patient actually falls. And I think that there's no good answer to this, but you have to rely on what you know, the fact that your intent is good and that you have specialized knowledge and the aid of various tools to try and come up with the best answer. Because ultimately, nothing is certain. There are probabilities involved in all of this. All of these risk calculators kind of look at an average patient. They may not reflect the patient that you see. That patient may not be in the registry, because this is kind of data that we've looked at from hundreds of patients that are maybe similar, but they're not the patient you're seeing. So there's always going to be some room there for surgeon adjustment of the risks and certain uncertainties that are, I think, intractable. So some conclusions, I think that, again, decision-making can be fraught with uncertainty in this setting, but I hope that this has given you at least a little bit of a framework to help make this an easier process as you move on in your careers. I think establishing the patient values, this is really the hardest part of this conversation, because the examples always seem very clear-cut. You ask the patient what they value in life, and then the STEM response will be like, okay, I only want to live if I can eat ice cream every Sunday. It's very rare that the patients will give you something that is so clear cut, and sussing out what they actually want and what that means to them, that's hard. And I don't have a good answer for that, but I think it's critically important that we really reflect on how to become better at those conversations. There are validated tools like best case, worst case that can help facilitate these conversations. And then just the last bit, and this is kind of my soapbox, is that surgery is so much about technical skills, but every year I have been a surgeon, and especially in education, I think that the non-technical skills are so important. And this is the thing that separates a technician from a surgeon, from being a technically proficient surgeon, from being a great surgeon, is really being able to hone these non-technical skills. Learning how to tie knots and do an operation, that's the easiest thing. Like, yes, you have to learn it, you have to practice it. There's no disagreement about that. But non-technical skills, I think, are incredibly important. They're nuanced, they're hard to measure. And they're hard to practice, but they can be practiced. And so I would hope that what you'll take away from this, in addition to these learning objectives, is next time you have a conversation like this, just like you would after an operation, think about what went well, what could have gone better, what would you do differently next time? Because I think that oftentimes the only way to getting this experience is by actually doing it. And so we have to be very deliberate about how we practice and reflect on that. Again, these are the learning objectives. I won't rehash them. I think we hit all these points. And so I just want to say, again, thank you for the privilege of your time at the podium, and I'm happy to answer any questions you have.
Thank you so much, Dr. Patel, for really very thoughtful grand rounds. I really appreciate you taking the time. And I want to send our heartfelt welcome to our applicants on Zoom. Thank you for taking the time to join us. In the spirit of this shared decision-making, I'm reflecting back on the time we met around Christmas in my house. This is an example of non-shared decision-making. I prepared coffee and cashew nuts for Dr. Patel to realize he doesn't drink coffee and has cashew nuts allergies. So questions for Dr. Patel.
Okay, let me start. So excellent presentation, and I will let all the residents know one way or the other you will land up in this situation. So be prepared for that. So my first question is, if the patient has signed DNR a couple of years ago and came to the hospital and they're not disclosing the DNR, then what should we do in that situation?
So I think if you don't know their code status and it's an emergent situation where you're going to assume that they're kind of a full code, like an implied consent. So I think that the basis for this is kind of what would an ordinary person do in this situation. So if someone shows up and they're, shot in the abdomen, we assume most people will want you to try and save their life. And so I think that's kind of the situation there. Sometimes the DNR orders, they come to light later. We don't know about them. And so that, I think is, again, part of that required reconsideration. If they have something that's explicit and you don't know about it, then I think you have to deal with it as if it doesn't exist. But once it becomes available to you, then again, it's a discussion with, either the patient or their family.
Yeah, no, family signed the DNR, patient signed the DNR. So we kept the patient conservative treatment for 4 or 5 days. Now the patient is crashing, we intubate and patient landed in ER. Now the family is coming and saying, oh, these are not the patient wishes. So now what? We'll end up in another situation. They never disclosed the DNR. Now they're saying they are not a patient wishes. They're still not disclosing what are the patient wishes. They're just saying it's still no patient wishes.
I mean, if they're
more complex then.
Yeah, those are always challenging situations and they come up. I think that's where ethics can be helpful for you. So every hospital will have some kind of system to deal with those complicated dynamics. I think if there's a signed, legal notarized DNR, then you're obligated to honor that. And if the family is telling you that, that's what the patient wants, then that's great. But if you don't have that documentation, it can be difficult if you're getting conflicting reports.
Yeah, but those are kind of challenging situations too, because patient find DNR, when you want to do something, the family saying these are not patient wishes, and then within 24 hours, they want to withdraw the care, because that can land in a very challenging situation, because with the DNR in effect, patient will never go to the OR. Anesthesia will never take the patient to the OR.
So I think that's, one of those things that gets nuances. So if a patient has a DNR, that doesn't mean that they can't go to the OR. And I think that's an education thing and a communication piece with colleagues. So, if you look at, the hospital policy, there's nothing in there that says that you cannot, have a DNR in place when you go to the OR. You just have to have that conversation with the care team in the OR about what you're going to do. If the patient arrests on the table, you all have to know that, the discussion that we had beforehand is the patient does not want defibrillation, do not want chest compressions, they're going to die in the OR. And that is very uncomfortable for people, especially I think, the OR nursing and anesthesia staff, because that no one wants a patient to die in the operating room. It is a terrible experience, but sometimes that is what you have to do to honor the patient's wishes. So just because that's in place doesn't mean that they can't go to the OR, but you do have to do that required reconsideration step. One of the things that they point out in these geriatric standards is that, most surgeons, and I think this speaks to that, when the patient signs up for an operation, the surgeons, 61% of surgeons feel that the patient is signing up for everything else afterwards as well. That means, the ICU stay, the mechanical ventilation, the attempted resuscitation, they're on board with the whole picture. And I think that, again, can be a disservice to the patient because sometimes they're not sure and there's uncertainty, and it may be reasonable to try this intervention. And if things go great, fantastic. But if they're not going well, then we're deviating from the patient's wishes. And as hard as it is, like you've done this great operation, you tried so hard to salvage this patient's situation, but you're kind of forced into this situation where the right thing to do, I think, is to, treat them in accordance with their wishes. And I think that can be very uncomfortable, for surgeons. You feel like you're not doing the right thing for the patient. They could, survive. But, what I try to think about is that, it's not about me, it's about the patient.
Yeah, that's the main thing is if the DNR is never disclosed, wishes were never been addressed, the ethics committee, compliance and palliative committee were never on board, we're never able to understand what the whole situation is. And then you will end up in a situation like, okay, these are not a patient wishes, but they never disclosed, never discussed. So that's the thing we have to be more careful about that.
Thank you, Dr. Singh. Other questions for Dr. Patel?
Wonderful talk. I wanted to get your thoughts on this idea of making recommendations. And, I think there's kind of two, or there's more than that, two phenotypes of the way surgeons handle these conversations. There's the people that are very upfront with their recommendations. And then the other side of that, there are surgeons that, will have a patient ask them to make a recommendation and they will say, well, I can't make a recommendation. And I think a lot of that comes from either that surgeon feels that the patient's values and wishes are not the same as the surgeon's potentially. And so they don't want to make a recommendation that doesn't align, or it's out of an attempt to not be paternalistic and kind of continue that kind of old physician-driven decision-making model. And so I wanted to kind of get more thoughts on how do you make recommendations for patients when maybe their end of life values don't align with yours, or, how do you navigate that? When do you say, this is my recommendation? And that's nuanced, I think.
Yeah, I think that's a great question. I think to your point, because we've tried to really put the power back in the patient's hands, I think sometimes we skew much too far in the other direction where we put too much of it in their hands and we're asking them to make an impossible decision that they are not equipped to make. And that's where I think it is important that we have to offer a recommendation and that's the hard part, is that you're trying to, filter through the lens of what you understand their values. And if their values are different than your own, or they're like markedly divergent, I think is the situation where I think it is the most troublesome or most challenging to deal with. It can be hard. I think as a practical point, again, in the acute setting, it's difficult because oftentimes you're the only one available. And so I think it's okay to express uncertainty to the patient. You can tell them, like, based on what I've heard, this is what I think. And I think you just have to acknowledge that, again, we're working in an area where the answer is not always clear cut. But it's important that, you support them in that decision making. You're giving them the best available information. Now, if you have a little bit more luxury of time or available resources, I think sometimes it can be helpful to get a second opinion and utilize your colleagues for that. This is where the palliative care team can also be really helpful, especially if you, again, have the luxury of a little bit more time, because they can really, engage with the family. And this is kind of what they have trained to do, is to elicit those values and kind of help them apply that to the situation that they're in. But unfortunately, I think oftentimes, as a surgeon, you will be performing primary palliative care, and that is well within your skill set. But you do have situations like this that are going to be challenging. And accepting the discomfort of this risk, I don't have a good answer for it, but it is, I think, something to acknowledge is very difficult.
Thank you, Dr. Hayes. And other questions from Zoom or in person from our residents or students or faculty?
Hello, this is Dr. Akhar. I'm going to start by congratulating Dr. Patel on a very lucid presentation of a difficult and sometimes nebulous subject. That was quite wonderful, and also congratulate you on your early career trajectory. Sounds like we can expect great things from you going forward. I want to make a comment and a question. First, as I've done before, recommend a book that reinforces and aligns very well with the principles that you talked about here. that's called Being Mortal by Atul Gawande, who's a Harvard surgeon, well-known nationally for his involvement in patient safety movement and in surgical economics and resource utilization. But you mentioned a lot about identifying the patient's interests and values in their outcomes, and we tend to focus as surgeons a lot on survival of the operation and the very short-term sort of measures and goals, time in the ICU, like you talked about. But what about the longer term expectations? How do you balance the short term, trying to get the patient out of the hospital, versus what they have look forward to should they survive to leave the hospital? How do you bring those things into the discussion, or how important do you think they are?
Dr. Patel, do you mind repeating the question so people?
Yeah, so I think thank you for the comment and the question, Dr. Akar. I think first I would second your recommendation of Being Mortal. I think Atul Gawande is a great writer. I encourage everyone to read that book. I agree it aligns very well. And I think to your question, which if I understand is how do you balance kind of the short-term metrics that we're really focused on as surgeons, like getting the patient out of the hospital, ICU length of stay, things like that, with what their long-term expectations are in recovery, and what does it look like when they do go home. And I think that's really important. And I think that that's something to kind of bring in to that storytelling framework when you use the best case, worst case tool. Because, even in the perfect world or the likely outcomes, a lot of these situations, as we all know, end with months of rehab. Every day in the ICU, I've heard this kind of rule of thumb is a week of recovery. And so that adds up when the patient has been in the hospital for, oftentimes 10, 14 plus days. And so I do think it is really important that we talk about what that looks like, because I think there's this, I don't know what kind of bias it's called, but there's certainly this urgency bias where people are so focused on the short term, this thing that's happening to them right now, where we do, lose sight of what life actually looks like. And I think that is really important. Will they become dependent? Is their functional status going to decline as a result of this? Again, I think we see that often, and unfortunately in young trauma patients, with severe head injuries, for example, where they, were fully independent, no medical conditions, and now they're likely to be totally dependent the rest of their lives. Older patients, sometimes that's a little bit easier where, maybe their functional status was, totally dependent prior to the operation. So maybe the recovery for them doesn't actually change much, but I do think it is very important to talk about what does life look like months after this, because sometimes if that doesn't look appealing to the patient, then it also makes the decision making much easier, even though it's really hard in the short term to kind of feel like we're not doing anything, but really we're achieving the goal of future life and quality.